Before beginning anything, a very happy World Physiotherapy Day to all the physiotherapists who are present here. Thank you so much for the efforts that you do to make the people fittest, happier and strengthful. So as we all know that the theme of this World Physiotherapy Day is low back pain. And today I am going to talk about a very notorious topic that affects a lot of cricketers, and it is lumbar stress fracture, as you can see. It has sidelined one of the most eminent athletes of our Indian cricket, and today we are going to talk about this. My name is Dr. Ashutosh. I am a PhD scholar at MIAS JNU Department of Sports Science and Medicine. Also, I am currently working as an assistant professor in the Department of Physiotherapy, University of Engineering and the Management. So let's explore some facts about the lumbar stress fracture. But before getting an insight, this is what Sir Don Bradman once said, that cricket is a team game played by individuals. But when individual suffers a serious injury like a lumbar stress fracture, it can actually affect the whole team. So today we'll focus on keeping those individuals strong and injury free. Oh, this is not working. So these are the two examples from the Indian cricket team. First is Jasprit Bumrah and other is Hardik Pandya, who suffered from these injuries recently. We know that the lumbar stress fracture actually affects more to the fast bowlers. And what could be the reason for it? When a bowler bowls, when he is bowling, around 7 to 8 times of the ground reaction force is coming. And he is bowling almost 150 to 300 deliveries per week. If we calculate it yearly, it is almost 6,000 to 8,000 deliveries in a year. So this is the amount of stress that he is bearing, and that too in the hyperextension position of the spine, with sometimes the counter rotation of the shoulder, which is the lateral flexion and axial rotation to the one side. And these all are the risk factors which are actually making these fast bowlers more prone to the injuries, the lumbar stress fractures. So talking about the epidemiology, amongst all the injuries of the cricket, bowling accounts for 40% of injuries, bowlers account for 40% of the injuries, and 33% of injuries are seen in the fielders and the wicket keepers. And of the bowling injuries also, around 33% injuries are from the back and the trunk. If we calculate all the time missed by a cricketer, almost 50% of the missed playing time in the cricket is because of this lumbar stress fracture. And around enormous 67% of fast bowlers will sustain this injury during this career. So this is actually a very career-devastating injury that can be experienced by a cricketer. Can we move to the next slide, please? So, before understanding the lumbar stress fracture, we must know little about the biomechanics of the bowling action. So for that, I would like to call a bowler. And we luckily have a very fantastic physiotherapist bowler today with us. So I would request Dr. Uday to please come on stage. So as you all can see, so please have a round of applause for Dr. Uday. So as you can see, there can be 3 types of bowling action. One, as you know, can be side on. You must have seen Bradley, Shoaib Akhtar doing this type of action. Then the next is the front on, done by the Andrew Flintoff, Mackay and Piri. And this is the mixed type of action, which is usually you have seen in the Lasith Malinga's bowling, or Jasprit Bumrah, or the Hardik Pandya's bowling. So Dr. Uday, can you please show us what a side on action looks like? Can you please face on that side? Yes. So if you see, if the batsman is on that side, his only one shoulder is facing the batsman when he is bowling. Can you please show us what a front on action is? So his chest is open up and his chest is right now facing the batsman, and both the shoulders are pointing towards the batsman. And the third action, which is the notorious action, it is the mixed type of action, which is actually the mix of both side on and the front on. And in this action, particularly the counter rotation of the shoulder is the main culprit. So can you please show us what a counter rotation is? So if you have seen, what he has done over here is hyperextension and then axial rotation on the one side excessively. If this counter rotation is more than 14 degrees, it has been seen in the researchers that it is linked to the stress fracture. So till now we know that this mixed type of the bowling action is actually the culprit of causing the lumbar stress fracture, and this is what was present in the bowling action of the Jasprit Bumrah and the Hardik Pandya. Thank you so much, Dr. Uday. So this is what I talked about. Mixed action can be of two types. First can be the hips on the side on and the shoulder on front on, or the hips can be on the front on and the shoulder can be on the side on. Can we move to the next slide? So there can be the other risk factors also for this injury. So I have pointed out some of the very important risk factors. First is the muscle asymmetry. It has been seen in the evidences that particularly the quadratus lumborum muscle asymmetry has been linked to the stress fracture of the lumbar spine. Not only that, the core stability deficiencies, bowling workload. If a bowler is bowling too much without getting the adequate amount of recovery, that can also lead to this type of stress fractures. Then the postural defects, because if someone is having a hyperlordotic posture or a kyphotic posture, this actually functions as a signature on which more complex motor patterns develop. So if someone is having a postural defect already, then he is also more prone to getting this type of stress fractures. And the next is the lower bone mineral density. It also leads to the bone stress fractures in the athlete. Can we have the next slide? Now, how the patient will come to us. So the clinical presentation of the patient will be that he will say that my pain is of low grade, but when I increase my intensity of the workout, my pain increases on the loading and specifically the axial loading of the spine. Then if the pain is actually mechanical in nature, that is dull aching, and particularly it is increased by the spinal side flexion, rotation and hyperextension. Oftenly you will see that there will be a localized tenderness on palpating that particular stress fracture of the spine segment, and the muscle spasms are also seen. One very beautiful test that we oftenly use is the stock test, in which the patient is asked to come on a single leg and he then hyperextends and rotates on one side. If the pain is provoked, then we can suspect there can be the injury of the stress fracture. And to confirm the diagnosis, can we have the next slide? We have to do the radiological examination. The first image is of the X-ray, then this is the CT scan and this is the MRI. In the X-ray, if you see, there is this Scottish dog-like appearance present on the first X-ray, which is saying that there is an injury of the lumbar stress fracture. This is the CT scan over at the yellow portion, you can see it, and then there is the edema in this MRI. So these are the radiological investigation that we oftenly use to diagnose the stress fracture. Can we have the next slide? So, talking about the intervention, so basically what the basic protocol says is, if there is active bone stress injury, the intervention has to be divided into 3 phases. First will be from 6 to 8 weeks, in which we have to protect the fracture. Second is 6 to 12 weeks, which is the protected reloading. And then in the phase 3, transition to the pre-injury function and return to sport. But this is not rigid. Actually, we have to decide our protocol based on the clinical presentation of our patient, and this can be modified according to the needs of the particular patients that we are seeing. Then, please back to the back side. Now, there are the important risk factors that we should also manage as a physiotherapist. In the researches, it has been shown in a bowling action, there is the rear foot and this is the front foot. So if the front foot of the bowler is having the less internal rotation, it has been linked to the stress fracture. So we have to assess the internal rotation of the hip also when we are checking the patients or doing the musculoskeletal screening of the patient. Next, if there is quadratus lumborum asymmetry, use any technique, MET, stretching or any other technique to correct this asymmetry. Then, ankle dorsiflexion range of the front foot has also been linked to the stress fracture. So, if there is any deficient amount of ankle dorsiflexion, we must improve it by movement with mobilization or any mobility drill that we may choose. Then, the last one that we oftenly do it in almost every patient, that is to improve the core stability. Can we move on to the next slide? But my favorite thing that we should never forget is the load management. That is actually causing the injury. You will be surprised to know that in Australian Cricket Board and the English Cricket Board, they have prepared the guidelines for the under 13 bowlers, under 15, under 17, under 19, which means that this is the amount of load that you should give to the players to prevent the lumbar stress fracture. But unfortunately, we do not have such guidelines from the BCCI, which can say that under 13 players can bowl this much amount of bowling or else. Can we go to the next slide? Now, this is the key thing of today's presentation. If I have to say you what you should take home from this presentation is this: acute to chronic load ratio. We should ask when an athlete comes to us, what is the acute to chronic load ratio? How will we manage that? How will we assess it? First of all, we have to see the workload in the last 7 days. For example, he is bowling 30 balls a day. For 7 days, it is 210 balls. That is for 1 week. Then in this manner, you will be calculating the load from the previous 4 weeks also, and then you will divide this present 1 week by the previous 4 weeks, and you should find out the ratio. If this ratio is from 0.8 to 1.3, it is known as the sweet spot. And over here, the injury risk is minimized. As you can see over here, this green is representing the sweet spot and the red zone is representing the danger zone or the increased injury risk. So, if we have calculated the acute to chronic workload ratio and it is coming from 0.8 to 1.3, it is wonderful. We should not see it. But if it is more, then we have to see what is the actual problem. Can we move to the next slide? Now, this is a calculation how I can see that we have calculated this is my Excel sheet in which I calculated the workload of a player. So on Monday he has bowled 24 balls, on day 5 Friday he has bowled 24 balls, that is 48 balls and in that week. And from the previous week we have got this data, current this is the acute and this is the chronic and this is the ratio that we have got. So this is from 1.6 ranging to 1.12 and this. So if it is in the sweet spot range it is green and if it is red we should tell the patient to go for the recovery. Okay, moving on to the next slide. Yes, the most beautiful quote as a sports physiotherapist, what I feel is that an ounce of prevention is worth a pound of care. If we can do something for the prevention it is better and do the ounce of care also, or the pounds of care. So this is a prevention model given by a very famous sports scientist, O. Bahar, in which he talked about the 3 things. One is the predisposed athlete, second is the susceptible athletes, and then at last stage it is an injury. So we have to manage all these phases. How will we manage it? By managing the internal risk factors which predispose the athlete to the injury. This can be the age, this can be the gender, body composition, health, physical fitness, anatomy or the skill level. Then we should know how to manage the external risk factors. This can be the human factors like teammates or opponents. It can be the protective equipment if there is deficiency in the protective equipment, or the environment. If the environment is too hot or too cold, it can also make the player susceptible to the injury. The predisposed athlete susceptible to the injury. Then the final nail in the coffin is the inciting event. So according to the playing situation, the susceptible athlete can get the injury or the player or opponent behavior or his biomechanical fault. So this is what we should focus on. There is not one approach that we must follow. Always it is multifactorial when we are assessing these kinds of player. So you have to think of very little facts that you know about that player and include it into the prevention of the injury or when you are managing the injury. Can you move on to the next slide? So this is the post-operative rehabilitation protocol for the stress fracture injury from 0 weeks to the 16 plus weeks, and this can be modified according to the clinical presentation. Next. Thank you so much, and we are open for the questions if there are any.